This is Dr. Paul. Thank you very much once again for tuning to our channel today. Today I want to talk a few minutes about malignant melanoma. As always, please visit us at our website at www.usmlevideos.net. That is www.usmlevideos.net, where we post our videos regularly. Today I want to talk a few minutes about malignant melanoma. You see, to diagnose this condition, it could be a flat lesion or a elevated lesion, and it will have an irregular border, and there will be also color variation. Now, why should we know about this disease? It is the leading cause of death due to skin disease. In 2007, some 59,000 people were diagnosed with malignant melanoma, and a lot of them will die. A majority of them will be diagnosed before the age of 40. And overall survival, the good news is it is increasing. It used to be 60% in the 1960s. Now it is 85%. Why? Because we are detecting malignant melanoma quite early. Now, the most important prognostic factor is tumor thickness. If it is thicker, it spreads more and it kills more people. It is less than 1 millimeter, it is like 95% survival rate. If it is more than 4 millimeters, it is like 30%. And if lymph nodes are involved, only 30% of people live to say 5 years. And so tumor thickness is a very, very important factor when we think about the prognosis of malignant melanoma. Now, clinical histological types include, number 1, lentigo maligno melanoma. It is chronically exposed skin areas will get this. Number 2, superficial spreading malignant melanoma. So lentigo malignant melanoma, superficial spreading malignant melanoma, and then the nodular malignant melanoma, like nodules. Then acral lentiginous melanoma on palms and soles and nail beds. Then malignant melanoma on mucous membranes, like anus or in the nose or in the mouth. So these are the basic types of malignant melanoma, and always look for an irregular border in these lesions, and always see for how much it's spread across. Always see the lymph nodes, how much they vary, and then color variegation. The colors, like it could be a pink, blue, gray, white, or black. And whenever you see those things, suspect it. Now, the most important mnemonic is ABCDE. A stands for asymmetry, B stands for border irregularity, C stands for color variegation, D stands for diameter greater than 6 millimeters, and then the E stands for evaluation. Whenever you see ABCD in a lesion, you should always evaluate it, and you should carefully follow it. Now, when you see these ABCD, look for other signs also, like bleeding. If there is a bleeding, it's an ominous sign. And look for which mole is just standing up. There is a sign called ugly duckling sign. Ugly duckling sign is if a patient has so many moles, and if one of the moles is standing up, you should always suspect malignant melanoma. This is known as a ugly duckling sign. Now, let us see when we should always consider a referral. If ABCD is there, always consider a referral, or at least follow that lesion, because the lesion is evolving. When do we say it is evolving? Whenever there is color variegation. If the color is changing, if the size is changing, if the border is changing, you should always suspect malignant melanoma. And it is the most common kind of cancer in so many people. So you should never leave this unattended. And always a referral is appropriate if you don't know what to do about it. And many times, patients like seborrheic keratosis, SK, they can resemble malignant melanoma. So not everything that looks like malignant melanoma is malignant melanoma. It could be a seborrheic keratosis. So always go for a biopsy. Now, superficial spreading melanoma is largely a disease of white people. In other races, especially people of color, you will see other types of melanomas, particularly acral lentiginous melanomas. And acral lentiginous melanomas, they occur as dark and sometimes irregularly shaped lesions on the palms and soles as new, often broad, solitary, darkly pigmented longitudinal streaks in the nails. So palms and soles in the feet and the nails, acral lentiginous melanoma. And many times doctors just don't go for it because you don't feel to do a biopsy on the palm of your hand. That's why most of these acral lentiginous melanomas, they go undiagnosed or neglected. So we should not do that, and even though it is hard, we should always go for a biopsy whenever we suspect a cancer. And dermoscopy, this is like a $500 instrument to look at a skin lesion, and it helps detect suspicious lesions that require biopsy. Now, in experienced hands, the specificity is like 85% and the sensitivity is like 95%. Now, treatment. Treatment is always excision. If you know that it is malignant melanoma, you should remove it. Don't waste any time. And how much you remove depends on histologic diagnosis and the thickness of the tumor. If it is just a thin lesion, you take just a minimum of it. But if it is very, very thick, you should take a lot of margin. And more specifically, surgical margins of 0.5 centimeters for melanoma in situ and 1 centimeters for lesions less than 1 millimeter thickness are recommended. And sentinel lymph node biopsy, that is selective lymphadenectomy using preoperative lymphoscintigraphy and intraoperative lymphatic mapping, is effective for staging melanoma patients with intermediate risk without clinical adenopathy and recommended for all patients. So it's very, very important that what you do with these excision depends on how much is the thickness of the tumor. Now, those are the main important points. So, ABCDE, those are the main things. Then take the biopsy, then excise it. Those are the main few points with malignant melanoma. I hope you got something. And as always, I recommend USMLE Smasher. USMLE Smasher is a very, very important book, and many people are writing to me, and it's a very important book. Don't waste your money on expensive courses. Read USMLE Smasher, and you will pass your clinical skills examination without doubt. So USMLE clinical skills exam, if you are taking that exam, buy this copy. It's available on Amazon and Barnes and Noble and other websites. That is USMLE Smasher. Okay, and visit our website also, www.usmlevideos.net. This is Dr. Paul. Thank you very much.